Okay, we're getting a few people online, so I might just do the boring stuff and get things going while people join. I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association. And I'll just start by acknowledging the traditional owners of the land upon which we're all meeting today and pay my respects to elders past, present and emerging. Thanks for joining the Health Services Research Association for Australia and New Zealand webinar. Just a reminder, these webinars are free, but I just encourage you, if you're enjoying them, please to have a look at our website and think about joining the association. It's a good time to join. One of the advantages of membership is a reduced registration for our conference, and we are still planning a face-to-face conference in Sydney on the 1st to 3rd of December. All the details are up on our website, and there's a full program going up next week, but there's already a lot of information about the keynote speakers, so that's a great reason to join. You also get access to our member-only methods education webinars that we've been running, and there's a library of those on our website as well that are open only to members. This morning, I think Juliana plans to talk for about 30 minutes, and then there'll be time for questions. And any questions you have while she's presenting, if you just type them into the Q&A button at the bottom of the screen, then the chair will put those to Juliana at the end of her presentation. I don't really have anything else to say, just a reminder that this paper that Juliana is talking about was one of the highly commended papers in our 2020 HSR Best Paper Awards. So I'm going to pass over to Rebecca Jessup. Rebecca is one of the newer members of our executive team, and she's an allied health lead at Northern Health and an adjunct professor at La Trobe University. And she'll introduce Juliana and chair the Q&A session. Thanks, Rebecca.
Thanks, Sarah, and thank you, Juliana. I'm so excited to be introducing you today, and really excited and looking forward to hearing your presentation. Juliana is a research-focused pharmacist who specialises in conducting pharmacoepidemiological research and health economics research, and she works currently for the Centre for Big Data Research in Health in Sydney. In 2018, Juliana received a Visiting Research Fellow Scholarship from Endeavour Awards and from CAPES Foundation in Brazil to undertake part of her PhD studies at the Big Data for Research Centre. At the successful completion of this program, she secured a position as a research fellow to investigate the use of medicine use and its outcomes using administrative and electronic health record data. And just a very quick reminder, if you do have some questions, please put them into the Q&A box, and at the end we will choose some questions for Juliana to answer. Over to you, Juliana.
Thank you, Rebecca, for the introduction, and thank you for those of you who are joining today or are watching this recorded presentation. So as Sarah mentioned, we'll be presenting this highly commended paper awarded in 2020 in the category of the best PhD paper by the Health Services and Australia Association. So this is the outline of my presentation, and I would like to start by talking a little bit of why adherence is relevant overall and about HIV adherence in the HIV context. And then I will move to the specifics of the paper and talking a little bit of trying to focus on the challenges of using administrative data for this type of analysis, and then moving on to some of the implications and future work that we are conducting. So I'd like to start as well by the definition of adherence to make sure we are all on the same page. And adherence is defined on the extent of which a person's behavior in taking medicines or diet or following lifestyle change corresponds to what it was agreed in terms of recommendations from healthcare providers. And then here I highlighted the agreed because it also is showing a more proactive role of patients rather than just following recommendations. And adherence is generally measured as a proportion of the time where patients are following those recommendations in terms of medicines could be related to timing, dosing, or frequency of taking medicines. So why adherence matters? Well, medicines are the most common intervention in healthcare, but only half of patients in chronic medicines, like for example, hypertension, diabetes, take their medicines as prescribed. So adherence is key in the pathway for treatment outcomes, and non-adherence is related to poor health outcomes and increased healthcare costs. So in Australia, just to illustrate, the inappropriate use of medicines represents 2 to 3% of hospital admissions, and this is even higher in older age groups and costs over 1 billion Australian dollars per year. Specifically on non-adherence, there was this study conducted by Cutler and collaborators, where they estimated in 2018 over $10 billion related to non-adherence for only 3 classes of medicines, for hypertension, dyslipidemia, and depression. So we can see here in this slide how adherence is important for health system efficiency, and why it is important to understand and know adherence rates in different scenarios. So in the context of HIV, the medicine's antiretroviral therapy is composed by the use of 2 or more antiretroviral medicines to block the HIV life cycle, meaning that the virus won't be able to replicate. So patients need to use those medicines in combination, and after a few months of use, the level of viral load in the patient plasma becomes undetectable. And this is really good for patients because it means they won't progress, the disease won't progress to AIDS, they will have a better quality of life, but also means that they can't transmit the virus to other people. And this recognition that undetectable means untransmissible also motivated treatment as a prevention. So everyone in Australia that is diagnosed with HIV would be invited to start antiretroviral therapy. But this combination is highly effective, but patients need to adhere in high levels to this therapy. So over 80% of the prescribed treatment should be used. And that would mean using the medicines in 24 days in a 30-day window, or at least 5 days every week. And this is important to achieve both the effectiveness and also avoid virus resistance. However, the treatment is effective, but it's a lifetime treatment because it does not cure the person from having HIV infection. So it is challenging to keep those high levels of adherence over time. And there is a meta-analysis from 2011, it's a little bit outdated, it's a little bit dated now, and it showed that only 62% of people on those medicines achieve the desirable levels of adherence in the world. And other reports in Australia show higher levels, between 70 and 85% of people reported achieving high adherence levels in Australia. However, these studies, they use self-report data, and they measure adherence in one point in time only. And why this would be a problem? Well, medicine utilization over time is not linear, so there are a range of events that could happen in the patient's journey that would interfere with the medicine taking behavior. So for example, adverse events or discontinuation to therapy or change in their daily routine. And it's estimated that between 20 to 45% of people will have difficulties in taking their medicines every day and would stop their treatment at some point in time. So there are a lot of developments in terms of therapy that could improve adherence, and I highlighted some of those here. And one of the most important is the development of single tablet regimens. And these single tablet regimens contain all the medicines that we mentioned, at least 3 medicines combined in one single pill taken once daily. And this helps to increase adherence by 40 to 60%. And in Australia, over half of the patients on those medicines already use single tablet regimens. Also, the development of more efficacious treatments with lower side effects and lower toxicities, such as the integrase inhibitors-based regimens. And these medicines are now recommended as first-line treatment, like over the world, but they can also be used as a strategy to simplify treatment in those who are already experienced. And more recently, there is this development of a long-acting formulation that will be administered once per month and might also help to increase adherence. So we are yet to see the effects of this strategy. So apart from the challenges in terms of the patient perspective to keep adherence, we have the challenge in terms of researchers and health professionals to measure adherence. So to begin with, there is no standard gold measure in terms of adherence, and we commonly use indirect measures to infer if patients are taking their medicines or not. And the most common used measure is actually by self-report and use of pharmacy dispensing data, which is the one that we use. So I just wanted to highlight that while self-report data is quite easy to use, it tends to overestimate adherence because it's subjective, and also patients can have is subject to recall and reporting bias. Whereas objective measures like pharmacy dispensing data are immune to those bias. However, they are a proxy of use of medicine. So patients, we would look at medicines dispensed and infer that patients were using those medicines that were dispensed. And in terms of performance, I wanted to highlight that pharmacy dispensing data are as good as self-report, pill count, and other techniques in predicting viral suppression. So this is another reason why those electronic databases are being used to measure adherence all over, for all kinds of medicines, not just in the HIV context. So in that in mind, we wanted to evaluate the patterns of adherence to antiretroviral therapy, but we wanted to look at this over time and using pharmacy dispensing data. And we also wanted to investigate the factors associated with having better adherence profiles. So in terms of methods, we use the pharmaceutical benefit scheme data collection. In Australia, medicines for HIV treatment are subsidized by the pharmaceutical benefit scheme, and patients obtain their treatment when they are prescribed by specialists or GPs who have undertaken specific training. The PBS data collection covers all medicines dispensed in outpatient settings and private hospitals, but it does not capture medicines paid in full by patients, dispensed for public inpatients, or obtained by clinical trial or compassionate access. So we used a 10% random sample of this data collection that is representative of Australia. In terms of selection criteria, we included all people who had dispensed antiretroviral dispensed between January 2016 and December 2017. And we included only patients who had at least 3 antiretroviral medicines dispensed at the same time. And we used this definition as a proxy of treatment for HIV because the PBS data set does not include the indication of the treatment. So we assumed that the use of 3 medicines at the same time was indicative of HIV treatment. So we followed patients for 1 year, 260 days, and we used prior data from July 2013 until the entry date to assess covariates, such as prior exposure to those medicines and prior use of psychotropics. What about the outcomes? So we estimated the adherence using the proportion of days covered, and we calculated the proportion of days covered as the total number of days that the person had access to 3 medicines at the same time, divided by the time period. And here we used 2 different time periods. So first, we measured the PDC over the whole year in 360 days, but also in monthly intervals, because we wanted to look at the patterns of adherence over time. And we classified as adherents those people who achieved PDC higher or equal to 80%. So within the year, this would mean 280 days of antiretroviral coverage, and within 30 days every month, at least 24 days of antiretroviral coverage. So you can see here in these figures the patterns of dispensing from the data set. And you have the regimen, the medicines dispensed, and their duration. So the first thing to calculate the proportion of days covered, that was a little bit of a challenge, was to assign the duration of treatment. Because again, the PBS dataset does not contain the duration. So for those patients using single tablet regimens, this was pretty straightforward. They were taking 1 pill per day, so the duration equates to the quantity dispensed. But for those using multi-tablet regimens, like we can see in this figure here, the panel A, we needed to consider the clinical guidelines recommended doses and the quantity dispensed to estimate the duration. The next step was to look at the overlapping days of duration of these medicines to define as a covered completed therapy. So a covered day, the overlapping of at least 3, and whenever patients had less than 3 medicines at the same time, we classified as an uncovered day, as you can see here in the second set of arrows. So because the definition is a little bit restrictive, we also conducted sensitivity analysis, changing and giving patients a grace period of 3 days, because as you can see here, they don't always fill their prescriptions at the same time. We also use more flexible definition, assessing a covered day as at least one, the use of at least 1 antiretroviral, and also we censored loss to follow-up to see the impact of loss to follow-up in the analysis. So using the monthly indicators of adherence, we built the group-based trajectory modeling. And this technique is really interesting because it classifies individuals with similar trajectories over time. And you can choose the number of groups in the model based on the size of the groups, interpretability, and also those with lower Bayesian information criteria. So this is an example from another study. They were looking at trajectory models for schizophrenia patients. And you can see how it can be hard if you have too many groups to interpret. And probably they were also assessing, as I mentioned, all those criteria to define which one is the best model. But what we can see here is that you have the months, every month of filling, and the probability of the patient being adherent over time. So this is the model 1, not the observed. And after you choose your model, you can also check the probability of each person being assigned to each group. And we have a threshold of 70% of probability to check if the groups were assigned correctly. And if you're interested in those methods, there is those references here in the bottom that are really good. And it's a starting point for studying the method. So after we define the trajectories of adherence, we compare the characteristics of people belonging to each trajectory group, and we assessed factors associated with belonging to the group with better adherence. And for this, we used a logistic regression, comparing all other groups versus people on the group with better adherence. So in terms of main findings, we identified over 2,000 patients using at least 3 medicines at the same time. Most of them were male. The mean age of 48 years, and most people filling their prescriptions from New South Wales, which is highly reflective of the epidemiology of people living with HIV in Australia. Over half of the patients were using single tablet regimens. Approximately half were using those new regimens I mentioned. There are integrase inhibitor-based regimens that are good with lower side effects and better and higher barrier to resistance. Most patients were on their current regimen for over 6 months, and almost 20% had used psychotropics in the prior 6 months that we used as a proxy for mental health conditions. In terms of adherence, we saw that a high proportion of people were adherent to therapy, so approximately 84%, but 1 in 6 would experience suboptimal adherence. So we wanted to flag that there's room for improvement here. And when we conducted the sensitivity analysis, and this was important to give us the upper bound of adherence, we noticed that sensory patients had the highest impact on adherence estimates, and that the true value of adherence would be between 83% and 88% of people achieving adherence. So using the monthly flags of adherence, we were able to identify 3 distinct groups of adherence over time. And most people, so 67%, belonged to the nearly always adherent group, which was a good thing to see. However, almost 1/3 had moderate or low adherence, which is not recommended. And here in this figure, you can see like every month, the proportion of patients who were identified as adherent, and also the solid line showing here the predicted values for each group. So when we compared the characteristics of patients by trajectory adherence, we could notice that, as expected, most people on the nearly always adherent group had a high proportion of days covered. All of them were classified as adherent within the whole year. And the other groups had a higher proportion of people with recorded treatment interruptions. So this was assessed by a gap of 30 days without any dispensing of any antiretroviral, followed by initiation. So people belonging to the moderate or poor adherence groups were more likely to interrupt therapy. And those people on the poor adherence group were also more likely to have only 1 dispensing over time. They were less likely to use single tablet regimens. They were less likely to use the integrase-based regimen that I mentioned that would be the recommended one. And they were less likely to be on the same therapy for over 6 months. And when we looked at the results of the logistic regression, we noticed that age, so each additional year of age would increase the probability of the person belonging to the best group of adherence, which is the nearly always adherent group, and compared to the integrase inhibitor-based regimen that I mentioned, a lot of other regimens for HIV treatment performed worse. So patients using integrase inhibitors are more likely to have a better adherence trajectory over time. And also those who were on their current regimen for less than 6 months were less likely to belong to this nearly always adherent group. So we found these 3 factors associated with belonging to the best group. So these were the main results. And the first thing that we did, obviously, was to look how these results compare to other measures in Australia. And what I'm showing in this slide here is the HIV diagnosis and cascade care of Australia. That is pretty fantastic. So we can see here that throughout the years, so from 2015 to 2019, in Australia, you have a higher proportion of people who live with HIV that are diagnosed, that are retained in care, that receive medicines and have viral load suppressed. So our question was, well, we found 84% of adherence over 1 year. However, a much higher proportion of people are virally suppressed. So what could be happening? So the first thing is that we could be underestimating adherence. However, our results were similar to other reports in Australia using surveys. The other thing is this HIV diagnosis and care cascade is a snapshot and may mask some of the individual behaviors over time. So there is data in Australia to suggest that patients interrupt their treatment and then they could reinitiate before their clinical visit and before getting the viral load test. And finally, new regimens can be more tolerant of non-adherence than we previously suspected. So in terms of strengths and limitations, this study was pioneer in assessing patterns of adherence over time in Australia. We used the representative sample that is comprehensive, it's a whole population perspective, and we had some insights that could be used for clinical practice. However, the limitations are that the dispensed medicines are a proxy of use. We may underestimate adherence because of those medicines that are not that dispensing, that are not captured, like the ones from clinical trials, or when patients are hospitalized in public hospitals. We had limited patient characteristics, so there are other factors associated with adherence that we couldn't measure. And finally, we couldn't assess the impact of the non-adherence on virological and immunological outcomes. So the implications of this study is that adherence is not a yesterday's problem, so it is still challenging. And while most Australians take their medicines as prescribed and they are adherent, we have a smaller proportion that maintain moderate or low adherence pattern over time, and this could impact their clinical outcomes. So using regimens with better safety profiles in terms of adverse events could help to increase adherence. And we also suggest increasing support among younger people and those in the early months of a new treatment regimen. Obviously, we wanted to highlight that characteristics of treatment are just a small proportion of what we need to change to improve retention of patients to care and to increase adherence. And these interventions should embrace other clinical, socioeconomic, and cultural factors. And I wanted also to highlight that this study showed how the PBS dispensing claims is available source to estimate the longitudinal patterns of use of medicines, so not just adherence. In terms of what we are doing now or future research, so following all of those challenges on defining adherence in PBS claims, especially because, as I said, in antiretroviral therapy is the use of multiple medicines at the same time, we developed a web application to help researchers to choose the best adherence definition. And they could look at the individual patterns of medicine use. So here I'm showing one patient, and then you can see the dispensing patterns and the results by using different definitions. And also the cohort results by age and sex or in the measure used. And we are going to be publishing this report soon. And we are also looking at other aspects of the pharmacological treatment that could help to optimize therapy, such as the use of co-medications and drug-to-drug interactions, because we know that increasing the number of co-medications can increase complexity of treatment, and this would affect adherence and effectiveness. And drug-to-drug interactions are also related to adverse events. And finally, I wanted to highlight that after we produced this study, other people from other groups are also using group-based trajectory modeling in the field of adherence, of HIV, sorry. And they are looking at this new technology that's called pre-exposure prophylaxis. And this is used not for HIV treatment, but to prevent HIV infection. So a lot of people now interested in assessing this new technology. It's not very new, but it was listed in PBS in 2018. And what I find interesting, so here I brought some of their results, that where most people, 73%, had either a perfect or a good pattern, excellent pattern of adherence over time. And here they have even a longer follow-up, but they were able to assess the impact of adherence in clinical outcomes. So they could see a relationship between having a poor adherence pattern, like this fast decline, was associated with higher HIV incidence. So here showing how those measures can predict the outcomes. And other studies also using the PBS data source to assess PrEP. And this will probably be published soon by one of our collaborators. So for more details, you can access the publication in full, and this is the pathway, or send me an email and I'm happy to take any questions that you might have.
Thank you, Juliana. That was absolutely fascinating. I'm going to kick off the questions. There is one in the Q&A already. Anyone who would like to ask a question, please pop it into the Q&A chat. I just wanted to very quickly ask you that stat on 50% of patients not taking long-term medication as prescribed, is that across all different types of disease groups, or is that just, wow?
Yeah, and only chronic.
Wow, chronic conditions, yeah.
Chronic conditions, yeah.
Wow, that's pretty shocking. I was very shocked by that.
Yeah.
Okay, so we've got a question here from Jason Ong. Really great presentation, Juliana. I may have missed this, but did you notice any association between adherence and time on antivirals? i.e., was there a treatment fatigue effect?
Yeah, so what we actually showed, if I may come back here, we classified patients according to their time on treatment. We didn't see, so this is the probability of belonging to the best group of adherence, so near the always adherent group. And we noticed that patients with a longer time on treatment, so higher than 6 months, which was the reference group, they were more likely to belong to this group. So anyone who had less than 6 months on therapy were less likely to belong, to have a better adherence profile. And there are some studies saying that patients that are on treatment for longer, they are more likely to adhere. So this could be related, for example, they have already passed the phase of adverse events, or they have adapted better to the therapy. So there is a little bit of a mix of explanations why, but those who are on treatment for longer tend to have better adherence patterns.
Great, thank you. Sorry?
I was going to ask if that clarified this question.
Jason, you can stick another note into the Q&A if you needed any further clarification on that as well. It's a really interesting use of big data, your study, and I'm just wondering if you have other examples of, routinely collected data that's being used in this way in the area of HIV in Australia or even overseas.
Yeah, thanks, Rebecca. So one of the things that we are doing now in terms of using routinely collected data, we are exploring the other potentialities of PBS data. So as I mentioned, we are looking at the use of co-medications dispensed in the PBS data set and drug-to-drug interactions. But apart from the PBS, there are some studies in Australia using data from Medicine Insight, which is data from GP practices over Australia and electronic medical records. So they are being used as well to assess not adherence to therapy, but comorbidities. So the thing is that they have deep data in terms of clinical outcomes, so they can assess other types of outcomes, such as comorbidities, testing, like the monitoring for side effects, for example.
Right. And you talked a little bit about the type of antiretroviral regime that patients are on actually influences is a predictor of adherence. Can you expand on what happened when you switched therapies for patients?
Yeah, so this was actually more on the methods. So we know that patients can switch therapy over time, but we didn't account for that in terms of attributing non-adherence to the new treatment. So we assessed if patients were adherent to therapy irrespective of what they were using. So in this figure here, for example, you will see that this patient switched therapy in the end of the follow-up, but we considered like any combination of 3 medicines to define them as adherent or not. I hope this is clear.
Yeah, that's great. And what does this study really mean for clinical practice? So should GPs actually be changing the therapy to get best results? What should we be doing in clinical practice?
Yeah, so this is the
$1 million question.
We are conducting the study for. So the idea here in terms of medicines is try to, whenever possible, simplify treatment. And we are not suggesting that everyone should change to an integrase inhibitor medicine, because if patients are well adapted, if they are virally suppressed with their current regimen, it doesn't make sense to switch. But what we're trying to say is that we need to give support to those patients. So for example, assessing adherence in every visit where you see the patient and asking the patients if they're having difficulty. So we propose the method using administrative data, but the GPs could use those surveys on adherence to actually check if patients are taking their medicines as prescribed or if they have any other questions.
Fantastic. I think there'd be a lot of GPs out there that would be pretty shocked to know that 50% of the time their patients aren't taking their medications as prescribed. Jason actually has another question here. I saw that you had 20% of people on psychotropic drugs. Did you find an association of that with adherence?
No, we didn't find an association, but we did adjust for that in our model, because it is a factor that is known to be associated with adherence. But here again, like the use of psychotropics, because the PBS dataset doesn't contain the indication of treatment, this was a proxy of mental health disorders. And so we know that some of those medicines could be used for chronic pain, or they could be used for, like to help people to sleep, and there are other indications. So that could be one of the reasons why we didn't find this association.
Great, Juliana. Thank you so much for your time today. It looks like there are no further questions, but if anyone, as you've said, wants to get in contact with you directly, they can. And if you want to pop your email address up again, there it is.
Yeah.
And again, really fascinating presentation. I really enjoyed it and I learnt a lot, and I hope everyone else on the webinar today also feels the same way. Thanks again. Sarah,
thank you everyone for attending, and thank you for the questions, and I'm happy to follow up if you have any interest in these or any further of the studies that I mentioned.
Thanks everybody. Thanks Juliana and Rebecca. And just to remind people that we'll have a recording of today's webinar up on our website probably by tomorrow morning. Thank you. Bye.
Thank you very much. Bye-bye.